Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc to Doc podcast.
Hello, I'm Steve Hoff, a board-certified cardiac and thoracic surgeon at Baptist Health Miami Cardiac and Vascular Institute. I specialize in adult cardiac surgery, and I'm a fellow of the Heart Rhythm Society.
Hey, this is Dr. Mario Pascual. I'm one of the electrophysiologists at Miami Cardiac and Vascular Institute, specialized in heart arrhythmia care, and also a fellow of the Heart Rhythm Society.
So on our previous show, we discussed the evolution in the past nearly 100 years with regard to technology and techniques that have brought us to the maze ablation era for atrial fibrillation procedures. In today's session, we're exploring guideline-directed medical, catheter-based, surgical, and hybrid ablation options for the treatment of AFib. We'll also visit the current guidelines for oral anticoagulation and their pre, peri, and post-procedural use. So Mario, I tell patients that the initial guideline-directed treatment for AFib is medical. Share with us your insights on initial medical therapy for AFib as it pertains to rhythm versus rate control and anticoagulation.
Absolutely, Steve. And, just exactly like you said, there's always two types of strategies for atrial fibrillation. And one arm is what we call rate control, and the other arm is what we call rhythm control. A lot of it is going to be driven by patient factors. I think patient age and underlying comorbidities will play an important role. But I think if we look back over the last 20 to 25 years of atrial fibrillation, more and more patients are candidates for what we call a rhythm control strategy. So rhythm control is when you're trying to maintain the patient in normal sinus rhythm for as long as possible. And the main reasons to do this is many times patients are very symptomatic when they have atrial fibrillation, or it can be contributing to other things such as a cardiomyopathy or heart failure symptoms. We really want to do our best. And traditionally, we've always had a line of antiarrhythmic drugs or antiarrhythmic medications that have done a decent job at best at maintaining normal sinus rhythm. And the other side of antiarrhythmic medications is that there's certainly some side effects. But you're right, the guidelines always recommended a trial or a failure of at least one antiarrhythmic drug before we considered some other type of invasive or innovative procedure for their atrial fibrillation. Problem is, a lot of times patients didn't like this because the side effect profile is pretty significant with these antiarrhythmics, and a lot of patients wanted a more definitive solution. If you go down the rate control, what you're trying to do now is just kind of control their heart rates, and there's kind of two sides of that. We weren't sure if we needed to maintain very strict control of their atrial fibrillation, or could we have lenient control? And the definition of that was what was their goal heart rate over a 24 or 48-hour period. And now we're pretty comfortable that if patients are asymptomatic and not candidates for rhythm control, if we can control their heart rate at less than 100 beats per minute, we know that in that patient population, we can reduce hospitalizations, decrease mortality, and those patients do quite well. The other side of atrial fibrillation is the anticoagulation. And it's actually always, and probably the same in your case, always the first thing we discuss with patients because, AFib can certainly not make you feel well. AFib can, be quite bothersome, but really what can be devastating to patients and their families is the risk of blood clot formation and the risk of stroke. So it's been around for quite a bit. We have the CHA2DS2-VASc score out there, and anybody who meets criteria with the CHA2DS2-VASc score, we initially talk anticoagulation. Luckily, we have direct oral anticoagulants that have been out for many years now, much better tolerated than the warfarin days, and much easier to take for patients. So once we kind of address their anticoagulant strategy, they can then go on to rate and rhythm control strategy. And Steve, that you're aware, but recently new guidelines came out for the atrial fibrillation. It's quite a handful. It's about, started reading them. There are about 60 pages of new guidelines there, and there's quite a bit on there. But, I think that there's one overwhelming theme of the guidelines, and it is now that, ablation, catheter ablation, or any type of intervention for a rhythm control strategy is far superior to any type of medical therapy and is far superior to rate control as well.
Let me ask a question, Mario. From a specific antiarrhythmic strategy, do you have a kind of preferred list that you use based on patient age, patient risk factors, that sort of thing, first line versus second line?
Yep, definitely. And, there's not many antiarrhythmics out there. There's, your 1C agents, which will be your flecainide and your propafenone. You have your class 3 antiarrhythmics, which is sotalol, amiodarone, and there's Tikasin, as well as Multaq. And that's kind of the end of the line there. And, with the antiarrhythmics, you're essentially kind of using the medication you can. And so there's definitely contraindications to the 1C agents. So if you have a healthy person with a normal heart, I think 1C agents, your flecainide and your propafenone are probably your good first-line therapy. They're probably best tolerated and the most limited side effects in terms of the long-term use of these medications. Problem with those is they're definitely negative inotropes, so you have to be very careful in the elderly patients. And they're absolutely contraindicated in anybody with any symptoms of heart failure, whether that's heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. I think we both share a little bit of affinity for sotalol. I think sotalol is an excellent antiarrhythmic, probably one of the better ones out there. Kind of used in a broad patient population, has minimal side effects, but it is broken down or metabolized renally, so you have to be careful with your creatinine clearance. And there's some data that suggests or recommends initiation of sotalol in an inpatient or hospital setting. Hasn't been our practice. Feel like we've been able to do that safely in the outpatient setting, but we certainly keep a close eye on these patients whenever we initiate our sotalol. Tikasin is I think our best antiarrhythmic in terms of efficacy, in terms of side effect profile. I actually always tell patients, in the initial trials with Tikasin, there are more side effects reported to the placebo or sugar pill than there were to the actual Tikasin. So I think patients get a cook of that and feel reassured that it is a medication they're going to tolerate for long periods of time. Two big limitations of Tikasin is, one, you definitely have to be loaded in the hospital. So your first 6 doses have to be in a hospital. So it's usually a 3-night, 4-day stay in the hospital to initiate it. And it's also renally excreted. So, if we start seeing drops in creatinine clearance, Tikasin's not our best option. And then we're left after that with amiodarone, which is a great antiarrhythmic, but unfortunately, the long-term side effects of amiodarone, I think, are very well known in the medical community. And so, I think a good choice, short-term meaning up to 6 months, maybe pushing it out to a year, but long-term just associated with a lot of toxicity, especially if you're using it for AFib. I think if we get into other indications of amiodarone like VT, and you assess kind of risk benefits of that patient population, maybe long-term use of amiodarone is reasonable. But for AFib, tough time accepting amiodarone as the best long-term antiarrhythmic. Multaq is good. I don't think it's very effective. It's a limitation of Multaq, and certainly also contraindicated anybody with persistent AFib or anybody with a history of heart failure, because it can have a little bit of a negative inotropic effect as well.
Got it. So as it pertains to the DOACs, I thought our audience might also appreciate your thoughts about any preferences that you have among the currently available choices for patients with AFib.
Yeah, in regards to direct oral anticoagulants, again, kind of looking at the patient population we're using it in. I think, both trials, the initial trials with Eliquis, demonstrated superiority to warfarin. That has been, difficult to reproduce. Xarelto was non-inferior to warfarin on the initial trials. I think again, looking at your patients, Xarelto or rivaroxaban certainly has a little bit higher risk of GI bleeding, but it has the huge benefit that it's once daily dosing. So if you have patients who have a little bit of trouble with adherence, or I think any patient like myself, where if you give me even an antibiotic for a 7-day course, I'm probably missing a couple of days there. I think once a day dosing is definitely right for me and for a lot of patients. But if you have a patient who's high risk of bleeding, I think, especially GI bleeding, I think apixaban is probably the preferred medication. Eliquis or apixaban is also very well tolerated by patients. You rarely hear side effects. Rivaroxaban can sometimes, cause some associated side effects to it.
Got it. Appreciate that. So when patients have failed medical therapy, whether it's because of a lack of rhythm control or side effects from medical therapy, I tell them they're sort of at a crossroads, and they either go down the road of rate control and anticoagulation, which probably 5 million people in this country take, or an ablation procedure. So give us your thoughts about catheter-based options, given the recent guidelines for the treatment of those patients decide to go down that road.
Yeah. And, I think, as you said, once they fail medication, they've traditionally had a class 1 indication for catheter-based ablation. And with the guidelines, which just came out a week ago, any patient who has, symptomatic atrial fibrillation now has a class 1 indication to go straight to catheter-based ablation and not have to fail medication. And there's a specific subset of patients, especially your paroxysmal patients, and we'll talk about why in a second. And importantly, your patients with underlying cardiomyopathy. Over the last about 3-4 years now, multiple trials came out. And before, when we were ablating patients with underlying cardiomyopathies, we weren't sure kind of what benefit we were having in those patients, and we were really helping them. And now, over the last 3 years, multiple trials have come out showing that we're actually have been able to decrease mortality and improve heart failure symptoms and ejection fractions in patients with AFib with an underlying cardiomyopathy. And so the guidelines have now reflected this, and I think very appropriately shown, especially in this population, don't mess with too many medications, optimize them from their heart failure standpoint, and go straight to a rhythm control strategy, most likely with catheter-based ablation at that time. And
I was going to ask, can you give us sort of an insight as far as your thoughts, advantages, disadvantages for radiofrequency ablation versus cryoablation?
Yeah. And so when you start talking, catheter-based ablation, we start talking pulmonary vein isolation and ablation for these triggers. And currently, there are 2 strategies, just like you said, or 2 energy sources. There is radiofrequency ablation and there is cryoablation. A little bit different approach with advantages and disadvantages to each. So cryoablation uses essentially cryoenergy or freezing, low thermal energy in order to cool the veins and cause cell death and cell membrane disruption by achieving low temperatures. It is what we call a single shot approach. So the way we do it is we put these catheters into the veins, we inflate this balloon, a nitrous material is injected into the balloon, causing freezing around the veins, which then cause cell membrane disruption of that tissue around the veins, which contains these triggers that cause AFib. Radiofrequency energy is similar in its purpose, but it does it by the opposite way. So it is a small catheter, usually about 3.5 millimeter tip, where that is taken up into the left atrium. Contact is made with the atrial tissue, and heat energy is applied, or electrocautery. The purpose of that is to also cause cell membrane rupture, but by reaching higher temperatures. So temperatures above 45 degrees Celsius have been associated with necrosis of those cells and scar formation. So by doing these different things, we can essentially eliminate the triggers. They've shown similar efficacy. So if you look out to about 3 years, the efficacy of both procedures are about 70 to 80%, and similar side of risk associated with each procedure as well. I would say the advantage of the radiofrequency, it gives you a little bit more freedom. You can kind of take your catheter anywhere you would like into the atrium and ablate that area, as opposed to the cryo balloon. You're kind of stuck to the anatomy of the balloon. The advantage of the cryoballoon is you're taking out or you're ablating a larger area at one time, so probably delivering a little bit more uniform lesions.
Tell us briefly about how you look at patients from a AFib burden standpoint, and where catheter ablation fits in there, and where more advanced, more vigorous ablations, potentially involving surgery, may play a role.
Yeah. So, when we talk AFib, we talked last time that, AFib is not just AFib. And, we used to traditionally, and I still do, think about AFib in three kind of stages: paroxysmal, persistent, and longstanding persistent. And the guidelines have now even breaking this up into stages. So, similar, we like to use the comparison to staging cancer. I don't like to talk to patients that way because, that is something that causes significant anxiety. But even the guidelines now kind of stage AFib. There's stage 1, stage 2, stage 3, 3A, 3B, 3C. It's getting more and more similar staging, cancer. But we certainly don't talk to patients that way. So we still talk about paroxysmal persistent and longstanding persistent. And I think when we look at paroxysmal atrial fibrillation, we know that addressing their pulmonary veins with catheter-based ablation is certainly the standard of care. We have excellent long-term data and long-term results with doing this. As the patient transitions to persistent atrial fibrillation, and especially to long-standing persistent atrial fibrillation, we know that their left atrium is really starting to remodel. And what we mean by that is these triggers that usually sit in the veins are now starting to kind of creep out into other areas, starting to really involve the posterior wall of the heart, starting to really involve the anterior roof structure of the heart. And, we always tell physicians, remember the heart is three-dimensional. So it has an endocardium, it has kind of a mid-myocardium, it has an epicardium. And with our procedures, I think we do an excellent job in getting endocardial. So we can get our catheters into the endocardium, deliver nice lesions. But, the limitation is that we're not going epicardial. And as we transition to these persistence and longstanding persistence, we know that there are more epicardial triggers than we'd like to see. And, there's been, several studies now where they look at epicardial triggers for patients with longstanding persistent AFib. And they've put catheters in the endocardium, have seen the endocardium itself in normal sinus rhythm and isolated, and they put catheters in the epicardium, and the epicardium is fibrillating, clearly demonstrating there's a disconnect between epicardial and endocardial kind of inputs there. And so once that patient starts transitioning to, the persistent and the long-standing persistent, I think that's when, we really want to get, our surgical colleagues involved here and start considering things like the Mays procedure, epicardial ablation. Steve, what's kind of your take? How do you look at these patients with persistent and longstanding persistent AFib?
Yeah, I tell patients, I think the same thing. What I tell them is, and we'll talk just a minute here, the last few minutes, about some of the surgical options, that if they have paroxysmal AFib, even the minimally invasive procedures that we have epicardially for surgery, which are extremely effective, have been shown to be equally effective as catheter-based surgery. If it was me, and I had paroxysmal AFib, and I could have either a minimally invasive surgery or a catheter procedure, I pick a catheter procedure all the time, which is why I'm one of your best referring physicians. But I think the role of surgery starts really with persistent and then long-standing persistent disease. So I look at surgery having that, that's really our wheelhouse. And to talk about surgical options for AFib, we have to start with the Mays procedure. That's, the crux of any ablation type procedure. You mentioned, the pulmonary vein isolation as being an important part of the basis of catheter-based ablation. That all came out of, Dr. Cox and his colleagues' data dating back to the 70s. We talked about this last time. And that's really the basis by which we've taken further technological advances. The Mays procedure has evolved over the years. The Cox-Maze 4 is probably the most commonly used procedure now. That's generally done as a minimally invasive procedure, usually through the right chest. The downside to that is it requires open heart surgery. It requires cardiopulmonary bypass and an intracardiac approach. So while these are often preferences of surgeons, and there are many surgeons in this country that are experts at doing that procedure, even Dr. Cox himself has said in a recent paper that the invasiveness of the Mays procedure has led to its limited use. And so, we've used it in limited indications in patients who require other concomitant intracardiac procedures, mitral valve surgery, that sort of thing, or in patients who have left atrial appendage thrombus that we just can't clear with changes in anticoagulation and that sort of thing. So we've used that strategy very effectively as a less invasive right thoracotomy approach, but it still requires cardiopulmonary bypass. Over the years, we've used the lessons that we've learned with ablation through the Mays procedure to apply it to less invasive approaches. And we have two from a surgical standpoint. We have an approach that can be done through bilateral thoracoscopy, either as a standalone procedure or, as you mentioned, in conjunction with endocardial ablation. And I believe that is the superior lesion set. And even Dr. Cox, in that paper that he wrote a couple of years ago, conceded that a hybrid epicardial and endocardial strategy like that, thoracoscopically, has the ability to perform the same Mays lesion set that we can perform with open heart surgery and should have the same results. And so that's something that we've seen, is that the results from that procedure, particularly in patients with persistent and long-standing persistent atrial fibrillation that can't really be managed well with a single or even multiple catheter-based procedures, have excellent results. There is a second type of approach that's approached through the subxiphoid space, where we use a different type of device that allows us to ablate the posterior wall of the left atrial appendage, of the left atrium, and is, very effective at doing that. The downside to that lesion set is it's lost the independent ability to create bilateral pulmonary vein isolation, which we've said is the hallmark, is the basis for our ablation. And so it's really has to be a hybrid procedure. Until a few years ago, we did it as a same day hybrid procedure. Now we've gotten a little bit more aggressive about doing that in a staged fashion. But as you might expect, since we can't provide the same Mays lesion set that we do with an open procedure, the results haven't been quite as robust. It also limits our ability to manage the left atrial appendage, which we can do through that bilateral thoracoscopic approach, which we believe is, was a basic part of Dr. Cox's, Mays operation development, and we believe is an absolute necessity during any type of surgical ablation. Here more recently, when we've done that sort of procedure, we and a lot of surgeons around the country have gone to adding a left thoracoscopy to perform an epicardial left atrial appendage ligation as a part of that. So those are both of the options that are available. We have experience of both of those here in Miami at the Heart and Vascular Institute, and it's I think a very important thing for us to have all those arrows in our quiver. I'll mention a couple of other things briefly about the surgery side. I've mentioned already kind of the hybrid approach. While we occasionally will see patients that can be managed with surgery alone, quite frankly, I think the power of the ability to perform endocardial and epicardial ablation as a hybrid type procedure, whether it's same day or staged, is an enormously effective treatment strategy. And so that, I think, allows us sort of the best of both worlds, right? According to Dr. Cox, we have the ability to, for these complex patients, to provide a full Mays lesion set with excellent results and left atrial appendage management. So I think that's been a very, very effective treatment strategy for these complex patients. The last thing I'll mention from a surgical standpoint is I think the importance of managing atrial fibrillation concomitantly. We see hundreds of thousands of patients in this country who have open heart surgery for other reasons, right? Coronary artery disease, valve disease, and a great many of those have a history of atrial fibrillation. And so it's an enormous opportunity for us to treat two disease processes. And I think that managing atrial fibrillation concomitantly, managing left atrial appendage at the same time is paramount. But as a surgical community, we don't do as good a job as perhaps we could. And that's something that I think is we looked at, and as a matter of, confidence in the Mays lesion set and education and that sort of thing. But the best data that we've got, which is improved data, suggests that if you're going to have a mitral valve procedure in the United States, only a little over half of those patients who have atrial fibrillation as well get their AFib treated. If you're going to have an aortic valve procedure or bypass surgery, that number drops to 25 or 30%. So that's been an area that we've tried to improve over the years and help our surgical colleagues with. So I think that hopefully that gives you a little bit of an idea of sort of the role of surgery in the treatment of really more complex AFib.
Yeah, and I think I definitely agree, Steve. And I think we have the patient testimonials to back that up. Multiple kind of failed catheter-based ablations and endocardial ablations, and then we go ahead and do a combined epicardial ablation, and and then they're just amazed by finally my AFib is truly gone. And it's a great feeling when patients say this. I'll say the other huge advantage of your strategy is the left atrial appendage management, not just addressing the anticoagulation, but, I think, we've learned that the left atrial appendage is certainly a trigger and responsible for induction of atrial fibrillation. And, we have a couple of things we can do in order to occlude the left atrial appendage, but we don't electrically isolate it. And with your strategy, the left atrial appendage certainly gets isolated, electrically isolated, contributing to the antiarrhythmic effects of your ablation. And Steve, one question I have is, I think you also have different energy types that you ablate with. Is there also thermal and RF? What are your catheters like? I think there has been some improvements and some evolution of that as well.
There has been. It's gone back and forth. We've, as catheter-based therapies have as well, we've used a lot of different things over the years. We've used radiofrequency, we've used cryo, we've used high-frequency ultrasound. We're interested in the exact same thing that you described very nicely, and that is the creation of cell destruction in a very limited way to create an injury that patients heal. And I tell patients it's that scar. It's not what we do. It's not the ablation itself. It's actually the scar that they create that allows the electricity to be those abnormal electrical pathways to be interrupted, allows isolation of those initiation foci to be stay away from the heart. And so as it pertains to modern surgery, I would say for the vast majority of surgeons and surgical procedures in the United States, we use two, and it depends on the approach. If we're talking about epicardial ablation, generally, we're talking about radiofrequency, although I certainly know some surgeons that will use both. It's very uncommon, and generally it's radiofrequency on the outside and cryoablation on the inside. And whatever strategy works best to help achieve that transmural injury that then becomes a transmural scar, that's what's going to be effective at doing what we need to do electrically to get people back in sinus rhythm.
Great.
So I think what we've seen, just to kind of wrap things up a little bit, is there are a great many options for the treatment of AFib and armamentarium. These are now well established, and as far as treatments of AFib, and we have a great many of these in our armamentarium and a wealth of experience at Miami Cardiac and Vascular Institute. The fields of catheter-based and medical catheter-based and surgical electrophysiology continue to change, though. And I think what we'll see as the future progresses is that we're going to continue to see innovation. maybe less in the medical side, but particularly in the interventional side with ablation technologies and surgical innovations. And so what we're going to do in our next episode is we're going to spend some time talking a little bit about some of these new technologies as they apply to the left atrial appendage and its importance in management of AFib, both endocardially as well as epicardially. And then we're going to talk about some really exciting things coming down the pike, particularly on the endocardial ablation side that we think will be available in the United States within the next year or so that could be game changers as far as ablation goes, as well as some advances that we're working on the surgery side as well. So we hope that you'll join us as we continue this Volume 3 of Doc to Doc, Masters of AFib. Thanks very much for your time. Mario, thank you always.
Thank you, Steve. That was exciting, and looking forward to the next one.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.